that we're just about to start, but kindly confirm you're able to hear me.
Yes, we can hear you loud and clear.
Thank you. Thank you so much. We'll start in a few minutes. Thank you everyone again for joining. Today we will be having the EHR team taking us through a number of items. One of the things that we'll want to focus on is on the quality of our documentation. We'll also be looking at privacy and confidentiality of patient records. This has come up so strongly in the last few days. And also we'll be looking at how do we prepare our medical reports and tailor make it based on the user's requirements or the needs of either the patient or the insurance company. So those are the elements that will be taking you through. Feel free to put in the chat your questions, your suggestions. If you have any other issues that you've not mentioned, if time allows, then we can be able to address it. But today I have my team here. We have Dr. Aftaab Khamisa, who's a physician informaticist. We also have Johnny Rungu, who's one of the nurse informaticists. We have, who else is here? We have Peter Moses, who's our nurse informaticist in the surgical module. We additionally have Maureen, operations and administration. Apart from that, we have Peter Tabu, who deals with oncology and Department of Medicine. Additionally, we work with the business process unit, and we have Business Netich, who's also joined in us to be able to address some of the issues that we might be having. So we'll start off right now with reviewing the quality of our documentation. So previously we were documenting on paper, and on paper it was quite straightforward, but right now we're documenting on the system. We've been able to create different templates, but how do you know which document do you initiate at which particular time? We've had people using a brief note. at what point should you actually use a brief note? If you've done an operation, what document are you supposed to be initializing? We will, at this particular time, we'll just talk about the documents that you need to do and when you need to do it. But remember, it's still your responsibility to make sure that it's as thorough and as detailed as possible based on your training. So we'll not be focusing on that at this particular time. But previously, we've talked about quick text, we've talked about formatted data to be able to enrich and enhance your documentation. So I'll have Dr. Aftaab Khamisa taking us through. So feel free to share your screen and kindly post your questions on the chat. And we'll additionally share the link for you to get your CPD points at the end of the session. Thank you. Aftaab, over to you.
Yeah, thank you very much, Mildred. And I just want to confirm that I am audible at this point.
Yes, you are.
All right. Thank you so much for that brief introduction. And I just want to highlight that we want to try and really run through today's agenda as swiftly as we can. I know Mildred has tried to include a couple of items, and she would like to ensure that they all get covered appropriately. And we also want to take some questions and some comments from the audience that is in attendance today. So I want to thank you all for attending this session. Today's topic that I will be highlighting is truly just centered around best practices of documenting a clinical encounter. Now, while I'm sharing my screen, I just want to highlight some of the basics that it's very important for us as care providers to try and absorb, try and adopt. And best practices are what actually allow us to standardize how we actually do things in a clinical setting. And one of the things that I really want to highlight today is the appropriateness of documenting that clinical encounter. Now, when I highlight the basics of this particular best practice, it's truly in keeping with what do you start with in terms of ensuring that you have appropriate documentation. So first and foremost, you must ensure that your patient is well identified, so you're on the right chart, that you've identified that you are in fact documenting on the correct patient chart. And usually we have a reference panel on the far right. So I'll just take this patient as in this test environment. All this information here is truly fictitious. So it causes no harm in terms of having this information being shared to a wider audience. And this is the reference panel to give us an indication that we are on the appropriate chart to begin with. And then obviously, depending on the clinical encounter, the expectation would be that you are either in one of three facilities as a care provider. So you can either be in the ambulatory facility or the ambulatory application, which is the one that's truly centered around outpatient care. You can be in the ED tracker, which is used mainly in our emergency departments. And then you can also be in the status board, which is web acute, the inpatient space. So I'm going to start off by just looking at one of the applications that I've logged in right now. As you can witness, this particular application is the ambulatory module. And I'll just go ahead and, apply a visit so that I can actually document. I want to start off by highlighting the importance of being able to identify correct documentation. Now we have an entire repository of documentation. And at this particular point, as you can imagine, there's a good variety of notes that a care provider has, privilege to select from. And based on that clinical encounter and the relevance of that clinical encounter, he or she is at liberty to select the note appropriately. Now, you can use certain features like favorites, which are the yellow stars that are attached to each particular enlisted tile of the document. And if I had to make, for example, the brief note a favorite, I simply just click on that yellow note. If I need a chronic pain management assessment note, I can simply do that. But my default as I log into, or at least launch that documentation tile, my default will be my favorites. So this is already a very nice preference setting that our users can use to really, identify the notes that they use more commonly. And then I also want to try and, highlight the need for making a selection on the appropriate documentation. Now, as you can imagine, within our office visits. Separately for pediatrics and separately for adult patients, we have what we call the adult office visit note. Then we also have the peds office visit note, and I'll make them both favorites, and you can see the differences between the two. We must be very meticulous about the choice of our note. Usually at this particular point in a clinical encounter, the note is initiated by the nurse. And because it's a shared template, the nurse already knows which note is more relevant in that instance. But what we have, encouraged is to try and ensure that we follow that process flow. What we try to discourage is the use of notes that are, free text, open notes. Like an example is the brief note. This is a very free text note. And a physician would have the liberty to write anything and everything that they want over here. But as you can imagine, it's just a free text. It doesn't help a physician in any way apart from just documenting some sort of a telephonic conversation that took place with the patient, where information does not need to transmit to another screen can be included here. And the reason why this note was made available to the clinical care providers is for such instances where there is some sort of communication that takes place with the patient, and you want to be able to document, and save to the chart that conversation that you had with the patient, including, what your plan was moving forward, whether it'll be a clinical encounter in, say, 2 or 3 weeks, or whether it'll be some follow-up labs that the patient needs to do, or maybe just self-reconcile some of the medication that was prescribed at home because of possibly an ADR. So ultimately, this is the functionality that can be used to document such encounters. And I'll not go through each individual note. I mean, by now, I'm sure most of you are already quite well versed with what each particular note entails. But in any event, if I need to just, switch between documentation templates, I can really just switch between them. And then what would happen is that a prompt would appear like this. So you can imagine a condition whereby you want to do an adult office visit note, and at the same time, you also want to prepare a medical report for that particular patient. And you can initiate more than one note by simply doing that and saying, yes, keep this document. So it'll sort of keep that document in a drafted status as the office visit note. And then I go in and pick up a separate medical report that I would like to complete for that particular patient. So very easy ways to sort of navigate through the system. And then as I've initiated this particular note, I can decide on how extensively I want to complete it and get a lot of that shared content coming in. Now, you'll notice that I mentioned shared content coming in. The reason why I mentioned that is because the system is so powerful to give you all that information within another note that may have shared content that was documented on a previous note. There's very nice ways to view previous and recall some of that functionality, especially where it's documented previously. In this case, I don't have anything documented for this patient, so it's not appearing. But by clicking on the three dots with each individual section, where you feel like the findings are quite consistent, they have not changed, is a status quo, or you're actually citing examination findings from a previous encounter, then it's easy to just pull it in at just the click of the button. And if I have to navigate across these templates, it's simple. Yes, keep this document again. And now I can scroll between and navigate between my two documents, and even decide to add a third one when necessary. I'm going to just briefly switch over to the ED tracker and also show you some of the functionalities that we have available here when it comes to documentation templates. So I'll select this patient as at random, is a Reg ER, and again, hit the documentation tile, and I wish to access that patient's chart. And then I can also go to all to see if there's anything that's in a pending state, or just go to show all. And in this case, you can see lots of these notes that are available here, are a replica of what's available in the inpatient repository, because the web ED tracker and status board are one application. So the dictionaries are one. What we would like to ensure is that there's some sort of jurisdiction on which documents you are entitled to complete and which documents you should not be doing in any instance, or which ones you're more encouraged towards completing. So for example, as an A&E or care provider, my expectation would be that at this particular point, I'd be doing what we call the ER note, right? So I have an adult ER note and I can make that a favorite. I have an ER record for peds, which I can also make a favorite depending on the cadre of my patients. I can decide on which particular notes apply to me more consistently. So the expectation will be that an ER physician completes an ER note. And following that encounter, if there is any form of a physical encounter that is taking place within the unit and the patient is still on the ED tracker, the expectation is that whoever is admitting that patient, he or she would complete an admission note. If at all the patient is now in, for example, status mode and is admitted and in the web acute space, then the care provider who's rounding on that patient is expected to complete a progress note. So as you can see, there are very clear-cut definitions between the application of the notes. This is not a new concept. We were doing this on paper as well. The only difference is that now we're doing it electronic, and previously we were doing it on paper. But in true essence, what we have is medicine has its admission notes, surgery has its admission notes, and likewise, all the other disciplines have their own specific notes. Progress notes are rounding notes, and consult notes are yet to be used when a new care provider or care team provider is being onboarded as part of a consult that was sent out. Those are just some of the basics that I wanted us to highlight. I'm sure most of us already know some of these things, but I'm happy to open the floor to any questions at this particular point.
Thank you, Dr. Aftaab. As the questions come in, I'll let you know. But it's for the rest of the team, it's important for us to initiate the correct note at the correct time. So as Dr. Aftaab has highlighted, depending on where you are, if you're in ambulatory setup, then you have different notes. If you're in ER, you have the same interface as what the people are seeing in the inpatient setup. Yes, Mohammed Han, yes, this training is CPD accredited. We'll be able to share the link at the end of the